Hi, Stephanie.
Hello, how are
How
you?
are you?
I'm good.
Um, so we'll get started in just a minute or so. Give about another minute to let some more people join,
Okay.
and then you can do your show. Is Sheila joining today too?
She's on vacation.
Okay, got it. Great. All right. Well, hopefully you can't hear the fire alarm going off in my building that I'm like reasonably sure is a test. But welcome everybody to our Friday CFAR conference. Today, we're going to start off with Bartlett updates, and then we'll transition to a few cases. And so I will introduce Stephanie Thornton to take us through what we need to know.
Hi, everybody. Thank you so much for allowing me this time and platform to share some brief updates with you guys. Again, I'm just going to get my screen shared. There. Okay. Can you see?
Great, that looks perfect, Stephanie.
Wonderful. All right. Okay, so I'm going to start off with just some key reminders for clinical operations, one being DME orders. So just a reminder that, when you guys are seeing patients in clinic and you put in orders for DME, the nurses, there's no in-basket message that we receive or notification. And so we don't know unless you guys tell us, or patients are sometimes calling and asking for status updates, and we have no idea that orders have been put in. So just to ask to let your nurses know that you put in an order for DME, you can send them a secure chat, a staff message, or just stop by the office and let them know. And oftentimes we do have to fax the orders and demographics and insurance information to these companies as well. And just another thing that I thought of after I finished this PowerPoint is when you're talking to patients, just let them know that the companies will reach out to them. It's not going to be the nurse. We usually don't get any notification. Northern Pharmacy, PharmaQuip, they'll call the patient. So they should be expecting a phone call from these external places in regards to their DME.
And
Number two, go
Stephanie,
ahead.
just real quick, could you just go over some what are the examples of DME that this is happening? Mostly
Yeah, so
what's
ordering canes, ordering like the pens, walkers, wheelchairs, anything that patients need that's not medication qualifies as DME. So those types of orders, if that makes sense. Number two, so vaccine and medication administration. So CMAs have been trained, and the training is going to be reinforced in the name of safety for them to document vaccine and medication administration at the time of administration. And so this means that they're going to need to have access to Epic so that they can verify the orders, verify the patient, and they're going to need some time and space to do that to ensure that we're adhering to the 5 rights of medication administration. So if you have patients in a hurry and you need the inmates to come in the middle of a visit, this is fine, but just please allow them the time and the space to make sure that they're doing all the proper verification. And it's probably more ideal to have them come in after so that they don't feel rushed. As we all know, when people feel rushed or pressured, that is when mistakes happen, and we want to avoid any medication errors. For patient rooming takes time. I mean, the inmates are doing vitals, they're doing med review, they're doing point of care testing. There are various screening questions that have to be asked. For those patients who are coming in for wellness exams, that takes maybe an extra 5 to 10 minutes. So just try to be patient and understand that rooming does take time. As far as team communication, we've been short on inmates for quite a few months now. We have 4 full-time and 5 part-time, and we have hired someone new. I don't know exactly her start date. And I think the inmates are doing a great job with the resources they have. But if there comes a time when you come out and you don't see anybody sitting in the zone or the workstation, and you need something for a patient, a EKG, medication, you can utilize the secure chat Bartlett group. and just let them know, hey, patient in room 8 needs injection, and everybody will see it. I'm on the group, Sheila's on the group, and someone will get to it. Just a reminder about checking in baskets daily for patient requests, medication refills, correspondence from your nurse. We don't have attending providers anymore who used to manage some of these tasks. So please just remember to check your in baskets daily. And then lastly, provider coverage. Please make sure that when you go on vacation, you assign a provider to cover for you in your absence. Nurses, although we are great and we do all the things, we are not, there are some things that's not in our purview or our scope. So we do need to know who's covering you. Any questions about that? Okay. And so moving on, before I jump into how wonderful we're doing with our quality metrics, I just wanted to take a moment to reflect. So yesterday I had the privilege of reflecting on 40 years of remarkable progress that we've made in HIV care, a journey that has truly transformed the lives of countless patients and really has redefined what is possible in healthcare. And as professionals, we've witnessed extraordinary advancements that have allowed our patients to not only survive, but thrive. And I feel that they're embracing longevity and aging with dignity. So I believe it's a true blessing to see our patients reach these milestones, needing mammograms, needing colonoscopies, needing annual wellness exams, 65 and beyond. Truly a blessing. And I think that it underscores our vital role, not just helping them live longer, but ensuring that they live well with optimal health and quality of life. And so as we enter 2025, I think it's crucial to shift the mindset around primary care metrics, particularly for our patients living with HIV. There's a common misconception that these metrics are solely about meeting financial benchmarks, but I feel that they are far more impactful than that. So I'm just going to go over a few reasons why we do quality at the Bartlett and why these metrics matter. So number one, they help improve patient outcomes proactively, not reactively. Metrics like blood pressure control, diabetes management, cancer screenings, they directly improve our patients' health and quality of life. As we all know, early detection through preventative care measures will lead to better treatment success and better outcomes. Also, these metrics, they really do drive evidence-based care. They help us ensure that consistent implementation of best practices are happening across the populations. And also the focused tracking enables identification of gaps and targeted interventions. So it's really useful for me. That's my role here, looking at the metrics on a monthly basis, identifying areas that we need to improve, and developing workflows, redeveloping workflows, researching best practices. They help build trust and engagement. I can't tell you how many times I've read opportunity reports and did chart reviews, and I've reached out to patients, and I found many patients on these lists, even though it may just be a patient overdue for a screening. But once I do the chart review, I realize, oh, this patient has not been here in over a year, and I'm able to contact them and get them in for an appointment. So it really does help with engagement, improve outcomes, foster confidence, patients' confidence in their care team, which is us. Also, transparent tracking and communication, it really does empower patients to participate in their health journey. When we're sitting in front of patients for visits and we have these care gaps in the health maintenance topic pop up for us, there's an opportunity to turn the screen towards the patient and say, hey, Mr. Johnson, you need this colonoscopy done. We need to get your eyes checked. You have diabetes, and diabetes can affect the eyes. Tell me what you think we can prioritize at this time. It also promotes long-term health and wellness. So proactive monitoring of chronic conditions and preventative care reduces long-term complications, and metrics help shift care from crisis management to a sustained well-being. And number 5, which I should have put as number 1, metrics are not just about money. They are tools for accountability and quality improvement, not just financial incentives, although financial incentives are great because we don't run off of peanuts. Financial incentives, they support better care delivery, but they are truly secondary to patient health outcomes. Okay. So just to move on to our tremendous progress. So this is October 2024, core primary quality metrics. I just also want to add that month after month when I'm in these meetings, it is always said how well the Bartlett is doing. So I don't pay attention to the red anymore. I look at the trend, and we are always uptrending. Since I've been here, every measure has consistently gone up. Even if we have a month where we dip down, we come back up. And so I think that that just is a testament to how well we provide care for our patients. So we have 5 measures that are outperforming October of 2023 and 3 measures that are within 5% of target. So breast cancer screening, the goal is 80%. We were at 70, and last year we were at 65%. Colon rectal cancer screening, the goal is 75%. We were at 68, and last year 65. Controlling high blood pressure, this is one of the measures that nurses have been working on, outreaching patients, calling patients. This has been a kind of a big push in the last few months, but we were at 71% with a goal of 77. And last year we were at 73. Depression screening, well above target. Our medical assistants are doing the screening, doing rooming. Our providers are following up, so great job. HbA1c, this is a reverse metric, so lower is better. And these are our medical assistants obtaining the point of care A1C at the time of visit, and providers also ordering this test for patients to come in and get it done. Statin therapy in our diabetic patients who do not have cardiovascular disease, we are doing well with that. Our patients are prescribed statins. And then well visits, something I'm extremely proud about. When I got here a few years ago, we were like in the 50%, 60%. We were at 77% in October with a goal of 80. And I have no doubt that we'll be at target or above within the next couple of months. So thank you guys so much for that. And then this is just a chart, a plot that just shows on the left here how well this is calendar year of 2024 compared to our last 2 years and how well we've been doing, and our forecast that we'll be above target very soon. For our diabetes care primary quality metrics, these are our diabetic patients. We want to make sure that their blood pressure is under control, their eyes are healthy, their kidneys are healthy. 2 measures have improved since October 2023. So our diabetic eye exam, we were at 63%, now 69 with a goal of 73. Our kidney health evaluation, so providers are doing a great job of ordering that microalbumin, and their patients are getting the EGFR done within their CMP. So we are above target there at 65%, much better than last year. And our diabetic patients with elevated blood pressures, we are at 73% with a goal of 76. Great work there. And I'm just going to quickly review some continued best practices. So these are things that we are doing already. I want to continue to do in the new year, and maybe a few additions. So number 1, outreach. I'm not sure if you guys know, but RNs have been given allocated and dedicated administrative time. And we use this time to outreach patients. We use this time to follow up with patients and try to engage them to get some of these screenings and tests and come in for visits and things of that nature. And so we'll continue that in the new year. Many of the nurses and providers have started this year care team meetings. And that's a good time to collaborate with your nurses during these team meetings to discuss our complex patients and address their overdue care gaps, and kind of work together to come up with a plan about how we can help them get these things done. And if you haven't had these meetings established with your care team, I would consider implementing them to enhance care coordination. From what I understand from those who have them running, they are very helpful. Our same-day workflows, I would say try to optimize the workflows to facilitate timely completion. So these are our patients who need the screening mammograms. We can't send them over to JHOC for diagnostic. And then JHOC 7, internal medicine, has graciously allowed us to send our patients over for the IDX retinopathy screening. Now, with that being said, you don't have to, but for those patients who we see month after month, and you guys have been ordering all the things and asking the patient to do these things, and they come back and it's not done. If they're here for a visit and they're within the time parameters that JHOC is offering these tests, if you could ask them, hey, can I send you over to JHOC to get this mammogram done today? Or can we just check your eyes? I just want to make sure you don't have retinopathy. If they're willing, Abina or myself or anyone will be more than happy to have help facilitate that. So those will be great opportunities for those types of patients. Blood pressure management. So these are our patients who walk out the door with blood pressures greater than 140/90. The X is that they have follow-up appointments within 6 weeks. This is for management. So the follow-up can be a provider visit, doesn't have to be, but if you want to see your patient within 6 weeks, it could be in person or telemedicine. Telemedicine for those patients who actually have a blood pressure cuff, and we do give lots of blood pressure cuffs away. They can have an RN visit. We can also have them come in to see us in person, or we can assess their blood pressure and give them education over the phone. Or for those patients who need medication management, we can have them scheduled with PharmD. For our annual wellness visits, we're going to continue to deliver exceptional care and complete these visits as they're due. If you have a patient that is here for a wellness visit and they're late, or they just have so much going on and we just can't get it done, we totally understand and we respect that. I just ask that you put in the wrap-up note within the visit encounter for the checkout staff to schedule them for another visit. And then for next year, I'm really going to be asking when you guys complete the wellness visits to coordinate with the PSC to not only schedule their 3 to 6 month follow-up, but also have the PSC schedule them for another wellness visit 1 year after the completion date. I'm not sure if you guys know, but Abena works really hard at flipping these visits. It's done internally. It's not something that's done with central scheduling at this time. And so I'm hoping that if we can have patients scheduled out, that will be less of a task for her going forward. And then lastly, transition of care improvement. So we are trying to brainstorm ways to reduce our readmissions and prevent medication errors post-discharge. So we have a new pilot in the clinic that we just started a few weeks ago, where patients who are discharged from the hospital with medication changes will not only see a provider for a transition of care follow-up, but also will see a PharmD to ensure comprehensive medication reconciliation. And that is all I have in terms of metrics. I just want to thank you guys again for all that you do. And I think that we can embrace these metrics as a roadmap for next year, a roadmap in excellence of care and a foundation for trust with our patients. And thank you so much.
Stephanie, I just have to say, that was amazing. It should be packaged and played again and again. What an amazing way to think about something that can often get reduced into what feels like another box to check. And you are 100% correct. So thank you so much for being inspiring about box checking, because it's way more than that. And I'm just so grateful for all the work that you do. I'll also just mention that I think the PharmD med reconciliation is a really fantastic innovation. As someone who's on PULC and then at the discharge, I get very nervous about what's going to happen when we've made a change. And I just recently had a patient who was discharged on a double dose of rosuvastatin, but still had his regular dose being loaded into his pill boxes. So we realized this, I manually went out and pulled them out of the pill boxes so that he could take the bottled pill. But this, I'm sure, happens all the time and usually with no big consequences. But what a great way to think about the tasks for a post-discharge follow-up.
Thank you. As always, I'm always here for questions, comments, feedback, whatever ideas you guys have, I'm open to them. Thank you so much.
Anybody else who has any questions or comments or just wants to pile on the kudos for Stephanie? Oh, I see some clapping. Well, thank you so much, Stephanie. Yeah. Yeah. I really appreciate it.
Eileen, I don't know how to do the claps on the thing, but Stephanie knows what an amazing job that I think that her and her team do, and it really helps me to get the right things for patients. So thank you. Just to echo everything you said, but less eloquently, Eileen.
Thank you.
All right. All right. So we will transition to our cases for the day. And before I get started with that, I also, I unfortunately was not in person